Today we are going to talk about pulmonary function test, right? Pulmonary function test, especially in relation to the ventilatory diseases, the disease of lungs in which there is problem with the ventilation disorders. Now, before I really go into detail of pulmonary function test, I would like to discuss what are the two broad categories of ventilatory disorders. Anyone? Basically, we divide the ventilatory disorders of lungs into two categories, obstructive category and restrictive category, right? So, we will be discussing on this side obstructive lung diseases, and here we will discuss restrictive lung diseases and comparison with each other. But before I really discuss both of them, I will draw a diagram related with the normal lung. Let's suppose this is a healthy person lung of a healthy person which does not have any obstructive problem and does not have any restrictive problem, right? I will just explain this, then I will draw the diagram in comparison with the normal lung. Let's suppose this is one lung and here are its airways in the cross section. These are cross section of airways, right? And as you know that airways are surrounded by the lung parenchyma, which consists of air spaces and alveoli, right? So let's suppose I make alveolar structures or other lung parenchymal structures around in which the airways are embedded. Now this blue area represents lung parenchyma, and this lung parenchyma, you must be knowing, is very rich in elastic tissue, right? So what we can say in this diagram, that there is lung parenchyma, and in that lung parenchyma, what are these? Airways, right? Now, this is normal lung structure, hypothetically. Now let's compare it with the restrictive lung diseases. What's the problem in restrictive lung diseases? In restrictive lung diseases, what really happens, that problem is with the parenchyma of the lung. Problem is with the interstitial tissue, right? And what is the real problem in restrictive diseases? That connective tissue here is increased. Problem is not with the airways. In restrictive diseases, problem is not with the airways. Problem is in restrictive lung diseases with the parenchyma of the lung, and in the lung there is inflammatory situations and there is fibrosis. Fibrosis means a lot of collagen is deposited. Now, if lot of collagen is deposited unduly in the parenchyma, lungs will become more stiff or less stiff? More stiff. So what really happens, that when there is restrictive diseases are those diseases which restrict the expansion of lung. What are restrictive diseases? Restrictive diseases are those diseases which restrict the expansion of lung. Why they restrict the expansion of the lung? Very simple reason. Because in restrictive diseases, problem is with the parenchyma, and there is either inflammation in the parenchyma, or there is excessive collagen or fibrosis, or some other you can say biological material deposition in the parenchyma. But in restrictive diseases, there is no significant problem in the airways. Now, when this parenchyma becomes fibrotic, right, naturally it becomes a stiff lung, so it cannot be expanded well, so it will become shrunken lung. So let's suppose if normal lung suffer with some restrictive disorder, right, then it will become a smaller lung. When it will become smaller lung, of course airway will remain the same, but the density of material here in parenchyma, that will increase as compared to the normal lung. Now why it is more dense? Because there may be more fibrotic tissue, or there may be more elastic tissue, or there may be inflammatory tissue, right? and when this parenchyma become dense, right, or there may be some infiltrative disease. Now airways are surrounded by lung parenchyma which is more stiff. Is that right? Now this type of lung which is suffering with such infiltration or by fibrosis or widespread interstitial inflammation, this lung is difficult to expand. Now you know that if this is the normal size of the lung, at the end of normal expiration, it means that this lung is at functional residual capacity, right? This is normal lung. Now functional residual capacity, when it is equilibrium point, that when you are doing the quiet breathing and you bring your tidal volume out, whatever is left behind is residual volume. Along with that, what else is there? Expiratory reserve volume, which is in total called functional residual capacity. When your lungs are held at functional residual capacity, that is an equilibrium point. That is the point where chest wall is trying to spring out and lungs are trying to collapse in. But in lungs tendency to recoil and chest wall tendency to spring out is absolutely equal. Whenever lungs tendency to recoil and chest wall tendency to spring out become absolutely equal and opposite, that is an equilibrium point, and lung is said to be at which status? Functional residual capacity. After that, with little effort, you will do inspiration and tidal volume. Now listen, if lung become fibrotic or infiltrated with a lot of pathological materials or processes, then lung will become more stiff, and when it becomes more stiff, it is less compliant. It is less compliant, and its elastic recoil will increase. Is that right? So it means that when lungs become stiff, or they become less compliant, or they become fibrotic, right, the inward pull of the lung is more. When inward pull of the lung is more, then naturally such lungs will pull the chest inward, even at equilibrium pressure. Again, let me make it clear. This was the chest wall here. What was going on here? That recoil inside and chest wall springing outside are equal, then we reach at this stage. But here, again, this is chest wall. Now recoil inside is increased or decreased? Increased, right? But outside pressure is same as normal, right? So this lung will pull the chest wall inward, and at equilibrium will be achieved at a smaller size. So it means in restrictive diseases, lungs will have smaller volumes. Am I clear? These will be smaller lungs. Now, so we can say in this case, functional residual capacity will be more or less than normal? Less than normal. Now, we compare restrictive with the obstructive disorders, right? And in obstructive disorders, now we'll see how a normal lung, right, what type of changes will occur into it when there are obstructive disorders. Now, before really I go into detail, I would like to tell what are the different obstructive disorders. Obstructive disorders of the lung have one thing common, that there is increased airway resistance. In obstructive disorders of the lungs, the common thing is that there is increased airway resistance. In obstructive disorders, main problem is not with parenchyma. Main problem is not with the elastic tissue, right? Main problem is not with the parenchyma, that parenchyma has increased in substance. Because when parenchyma is increased, it will become restrictive. In obstructive disorders, the real problem is with the airways, right? Now, what could be the reason why airways may be producing an obstructive problem, right? There can be three basic mechanisms. Let's suppose this is an airway, right? Now, why it may be producing some obstruction? One reason is very simple. When there is excessive secretions inside it, when there are excessive secretions inside, Can you tell me a disease in which chronically there are excessive secretion in airways and airways are chronically obstructed? Yes. Can you tell me a disease? One of the very common disease is chronic bronchitis. It's very common in smokers. In chronic bronchitis, the main problem is that someone who has been smoking for a long time, smoking irritates the airways, and airways love to clear the irritating particle. In that process, they produce more secretions. And when they keep on doing excessive secretions for many years, there is a hyperplasia of secretory glands and metaplasia of the goblet cells. The result is that such airways produce excessive amount of secretory material unduly, right? And when this is too common, person will have a clinical problem which we call it chronic bronchitis. Is that right? Even though it has more problems also, but most dominant is excessive secretions. Then clinically we define chronic bronchitis. Who will tell me what is chronic bronchitis? I don't want an essay on that, just basic concept. When you label a person he has chronic bronchitis, when some other doctor diagnose, when you label a person he has chronic bronchitis, this is clinically defined, a person who has, cough with expectoration for at least 3 months. Someone who has cough with expectoration for at least 3 months for at least 2 consecutive years. Right? That is chronic bronchitis until proved otherwise, because there may be some other reason also. Anyway, this is one reason for obstruction. Second reason for obstruction may be, normally airways are kept open by elastic recoil of the radial traction of elastic material around it. Let me explain it here. Now this is an airway. These are elastic forces around it. Right? Now these elastic forces are trying to pull the airway open. Is that right? So it's a very basic concept. If you are expanding the lungs, airways will open. Is that right? And if lungs are deflating, then traction on the airways will be less, and during expiration air will become little compressed. Let me repeat it. I've mentioned it previously, but it's worth mentioning again. That lungs are like elastic tissue in which there are holes. These holes are airways. When you pull this elastic tissue during inspiration, airways are wider than normal. And during expiration, when elastic tissue is regressing or recoiling, traction on airway is less, radial traction, and they become smaller in diameter. Am I clear? Now, one of the main reasons which keep the airway open, especially smaller airway open, that is the elastic traction of the lung parenchyma which is present around the airways. Is it clear to everyone? Now, another disease which is called emphysema. The problem in emphysema is, I will draw it here rather. Let's suppose these are alveoli. The problem with emphysema is that someone who has been chronically smoking, smoke particles are irritating the alveolar area, and alveolar macrophages and neutrophil are trying to engulf phagocytosed smoke particle. And if someone is smoking for a long time, it means there is chronic presence of carbon particle in alveolar area. It means there is chronic overstimulation of neutrophil and macrophages to phagocytose those smoke particles. As sometimes when you eat, your saliva may fall out. Sometimes only, I know, not regularly. In the same way, here these neutrophils and macrophages which are busy in phagocytosis, if they are doing it too much, during their eating process, they regurgitate proteolytic enzymes. And neutrophils and macrophages are eating the carbon particles, they keep on regurgitating or spilling out some proteolytic proteases, right? And some of these proteases are elastases, and those elastases destroy elastic tissue here. And when this elastic tissue is destroyed, do you think there's any traction on the airway to pull it out? No. So airway will recoil in, and that gets smaller. Again, let me tell you what happens in emphysema, right? Primary problem in emphysema is that there is excessive destruction of, alveolar walls, right? These are alveolar walls, right? There's destruction of alveolar walls, especially destruction of elastic tissue, right? Why? Because there's excessive elastases or proteases there, and there is excessive oxygen-derived free radicals. All these are coming from overstimulation of what? Neutrophils and macrophages. Usually when neutrophil and macrophages regurgitate proteolytic enzymes, there are normally antiproteases present here. But if in any person's lung, proteases are regurgitated and released more, and antiproteases action is less, then there is excessive destruction of elastic tissue and alveolar walls are lost. Gas exchange areas are reduced. This is one problem. Second problem will be the radial traction, the amount of elastic tissue which was pulling the airways open, that will be reduced. When radial traction on the airways will be reduced, what will happen to airway? They have a tendency to collapse, they become narrow, right? So actually in emphysema, airways become narrow, but these spaces become larger with less septa. Am I clear? With that, another thing occurs. Such type of lung in which elastic tissue has been significantly damaged and destroyed, do you think it is more stiff or less stiff? It is less stiff. It's like a loose elastic. Is that right? Such lung in which there's significant loss of elastic tissue, classically in emphysema, lungs become less stiff, lungs recoil become more or less? Less. And lungs compliance become more. Lungs are more compliant to the pressure changes. So such lungs, inward pressure will be more or less. Such lungs in which elastic tissue is destroyed, their inward recoil as compared to the normal lung is more or less? Less. If their inward recoil is less, then chest wall will pull it outward and their lungs will become larger. At which stage? Functional residual capacity. So such lungs where there is obstructive problem, they become larger lungs, right? But larger lungs with smaller airway caliber, right? And with less dense, what is this? Parenchyma. Because there is less traction on the airways. Now this is a lung with obstructive problem, for example in emphysema. Is it clear? And when you compare this lung with the normal lung, what's the real difference? Airways are smaller, right? And alveolar spaces, if it's emphysema, because septa are destroyed, they look larger. And even the overall lung size is also larger. So I said obstructive lung diseases may produce obstruction to the airflow in multiple ways. One reason was chronic bronchitis, excessive secretions. Second reason was emphysema. And in emphysema, what was the problem? There is reduced radial traction on the airways. Is that right? And another reason, in another pathophysiological problem, there is increased hyperreactivity of smooth muscle. There is another condition, you will tell me the name of the disease, in which smooth muscles are hyperreactive in the airways, plus there is some signs of allergy, usually eosinophils are there, and there is some degree of inflammation also there, and usually this disease is episodic. What do you think? What is it? Asthma. That's very good. This is asthma. Now, chronic bronchitis, emphysema and asthma. All of them are obstructive lung diseases. Here obstruction due to excessive secretion. Here obstruction because airways are no more pulled outward due to reduced radial traction, which is due to reduced elastic tissue. Emphysema. And in asthma, there is not only inflammation of airways, there is also excessive hyperreactivity of airways, and there are a lot of inflammatory mediator which make these smooth muscles to spasmodically contract. Right. Now, out of these are all obstructive lung diseases. Now, out of these three, which are classically called chronic obstructive pulmonary diseases? All of them or some of them? COPD or COAD, chronic obstructive pulmonary diseases, or chronic obstructive AD, airway diseases. All of them are same in this category or some of them? Some of them. Which one? First two. They are always chronic. Chronic bronchitis is of course chronic, it is not acute. And emphysema is a chronic problem because once elastic tissue is destroyed, it is lost forever. Right? So both of them are called chronic obstructive pulmonary diseases. Asthma should be classified separately, even though asthma is also obstructive disease, but it may be acute sometimes. Acute episodic. Am I clear? Now, if we have discussed this thing, let's compare the compliance of these three lungs on single graph. Let's suppose here we put the pressures which expand the lung, and here we put the lung volumes. Of course, all of you know that when pressure is more, transmural or transpulmonary pressures are more, lungs will keep on expanding. If this is the normal curve, what this is showing, when pressures are increasing from 10, 20, 30, 40 centimeter of water, of course, when intrapleural pressure or transpulmonary pressures are increasing, lungs volume is going up. Is that right? Now, you will tell me, I will draw an upper curve and one lower. What do you think? This is suppose first and this is the second. Which one of these two represent restrictive lung disease? Upper or lower? Yes? Lower one, because in lower curve it is showing this is a problem related with this lung. What it is showing, there is more pressure changes but there are less volume changes. This curve is showing that as pressure changes, volume changes are less than normal. It means this lung is stiff. This lung is hardened. It is stiff. It is less compliant. It is having restrictive disease. Right? In spite of significant pressure, filling of the lung is restricted. But when you compare this is showing the pattern here obstructive. What is happening here? Let's suppose it is emphysema, where elastic tissue of the lung has been significantly lost. Lungs are like loose elastic. With little stretch, with little pressure, they overstretch. For little expanding pressure, there is too much change in the volume. Right? So this graph is clear. That basically here what I am showing, this is the normal relationship between lung pressure and volume. Is that right? When as compared to normal, if compliance curve become rightward, lungs are more stiff and restrictive diseases. If it moves leftward, it means for a given pressure, unexpectedly bigger volumes are achieved. It means lungs are more compliant. It's a hallmark of obstructive lung disease, classically emphysema. Am I clear? Now, we discuss another thing related with obstructive lung diseases. In obstructive lung diseases, as I told you, airways are narrow. In all obstructive lung diseases, airways are narrow. When due to pathological process, your airways are narrow, then patient will have more problem during inspiration or during expiration. Who can answer me? Yes. My question is, I'm a person with airway problem. It may be asthma, or it may be chronic bronchitis, or it may be emphysema, whatever. But anyway, I have obstructive features in my airways. If I have obstructive features in my airways, I will have more difficulty during inspiration or during expiration. Yes, Zed. Expiration. You don't need to think about it. It's logical. You know why? Look here. If my lungs are like a rubber and airways are the holes in the rubbers, when I'm doing inspiration, holes are automatically becoming wider. So do you think during inspiration when lungs are expanding, again look, it's so simple concept. This is airway and this is just very simple diagram. This is elastic traction. If lungs are becoming wider during inspiration, expanding, there's more pull on airway. So there's less resistance. So naturally, inspiration is easier. In spite of the fact that there is some obstruction, problem during inspiration is less because whatever traction is there, it open it to some extent. But same person who has some degree of obstruction, when he is doing expiration and when lungs start getting smaller, traction on this is very less, and even in normal person, healthy person, during expiration, there is less pull on the airways. Normally airway becomes little narrow, but if there is already pathological obstruction, of course narrowness will be exaggerated. Am I clear? If I have to repeat it 1000 times, I will. That during inspiration, normally airways little expand, and during expiration, normally, physiologically, airway become little narrow. After knowing this thing, if I repeat my question to you, that person has chronic obstructive problems in his lungs, do you think this person will have more difficulty during inspiration or during expiration? During expiration. Is that right? Okay. It means that all these obstructive diseases, asthma, chronic bronchitis, emphysema, they have more expiratory problems. Is that right? Now what happens with them? Because inspiration is relatively easier and expiration is relatively difficult, as during inspiration resistance of airflow is less, and during expiration as airway become narrow, resistance is more. This phenomenon produces a problem with this lung. You know what is that? Every inspiration they pull more air in, but when they try expiration, can they get all the air out? No. It is just like this, that something is coming in through wider tunnel, but when it is have to go out, tunnel gets tight. Something may be left behind. What are you thinking? You're looking nasty. I'm talking about airways, right? I'm talking about airways, that airways, when air comes in, during inspiration they become wider. And during expiration, naturally airway become narrow. But if there is some obstructive element, then during expiration they will become too narrow. Is that right? Yes. Okay. Now, attention please, we are studying medical sciences. Now, what really happens, the real problem in chronic obstructive airway diseases is, one more real problem is that during every inspiration, they pull more air in, and every time they expire, a little air trapping occurs. You understand my concept? Right? It is about the lungs, that every time, yes, some air will be trapped in. Now imagine, if I'm having emphysema, suppose, of course in one day I have so many inspirations and expiration, and every time when I do expiration, little air is stuck in. You understand why? Because during expiration, when lungs are collapsing, already airways are very narrow, and when lungs are getting smaller, no traction, and some of the airway become very narrow or even closed, shut down. So progressively more and more air is trapped into lungs. So overall lung size will be smaller or larger? Larger. So lungs become really very big. Total lung capacity may become very big. It's just like this. Look at me. More, little air come out. More in, less air come out. More in, now you see barrel shaped chest. So what really happens in the patient with chronic obstructive airway diseases, that because during every expiration, airways become a little narrow as compared to inspiration. So every time the air system traps a little air. So lungs become air trapper. And when lungs become air trapper, you are understanding me, what will happen? Total lung size will increase. Total lung capacity will increase. Now, if these lungs are trapping more and more air, of course they become very large. Now, do you think it's easier to get the air out and achieve the normal residual volume? Even if person who has emphysema and he has taken too much air in, if you ask him, you will give him $100, he get maximum air out. Can he bring his lung such a small size as your lung during residual volume? No, because whenever he will try to hardly push the air, he will try hard expiration, very forceful expiration. Actually, he will bring too much pressure here and collapse the airways. So, a hallmark of obstructive disease, especially chronic obstructive diseases, lungs become very big and that chest wall is lifted outward and it looks like a barrel-shaped chest. Am I clear? There's no problem with this? Right. Now, let's study the same changes on spirometer. Again, first normal, then pathology. Let's suppose that these are, okay, we'll put it here, spirometric changes. First for the normal lung, tidal volume, inspiratory reserve volume or expiratory, what is it? Expiratory, then it goes for inspiratory reserve volume. What is this? Vital capacity. Now, this is normal lung, this one. In normal lung, what is there? Yes, there is about, how much is this residual volume? 1.2 liters. How much is this expiratory reserve volume? About 1.2 liter. How much is this? Half liter. And this is about, inspiratory reserve volume is about 3 liters approximately, depending upon your age, sex and your other factors. Now, about these two together are about 2.5 liter, including half liter, 3 liter and 3 liter this. From here up to here, how much it is? 6 liter. Am I clear? Everyone is following me? So this is normal parameters. What is this? Yes, residual volume. And what is this here? Expiratory reserve volume. And what is it here? Tidal volume. And what is this here? Inspiratory reserve volume. And what is this from here up to here? Yes, vital capacity. Very good. Now this is normal, right? All of you know that. Now we have to see this type of volumes and capacities, how they change in restrictive disease and how they change in obstructive disease, right? Let's draw the restrictive disease changes here. Now, first of all, in restrictive disease, lungs as compared to the normal lung, lungs are smaller or larger? Smaller. So total lung capacity is going to be more or less? Less. So it means if total lung capacity in normal person is 6 liter up to here, it should become maybe total lung capacity maybe 5 liter up to here. Is that right? Why the total lung capacity will be less? Because lungs are fibrotic and it's very difficult to expand them up to normal total lung capacity. They refuse to be so compliant. Is that right? Now, what really happens, again I will repeat, I told you because in restrictive lung diseases they are more fibrotic parenchyma and this is pulling the lungs too much inward, elastic recoil of the lung has increased and compliance has decreased, so lungs are getting more recoil power and they pull the chest wall in, so they operate at smaller size. When they are operating at smaller size, then it means that tidal volume will be moving here. Right? For example, it was here. Normally it was, what was this? Functional residual? Yes, functional residual capacity. Normally it is 2.5 liter. But in this case, functional residual capacity may be just 2 liter or 1.5 liters. It has gone down. Right? This is one thing. Secondly, if this person goes for inspiratory reserve volume, that will be less, and residual volume will be far less than normal. Here residual volume is far less than normal. You can understand that is a smaller lung. Is that right? Because this lung has more elastic recoil, when person will forcefully expire, lung will achieve smaller volume as compared to the normal lung. Right? So residual volume will be less. Functional residual capacity will be also less. Right? Now, we go for what? What is this here? From here up to here. Vital capacity. As compared to normal, here vital capacity is also less. It's very understandable. A lung which is very stiff, having restrictive feature. You cannot pull in lot of air and you cannot bring out lot of air. Is that right? What is vital capacity? First, deep maximum inspiration. You blow out as much air you can blow out, and all the air which come out is vital capacity. But if lungs are stiffened, first of all you cannot pull in much air, and after that if you want to blow out, the total air which comes out is far less than the normal lung. So vital capacity may also be decreased. But visually if you look and compare these two graphs, it's very simple that everything as a panel has gone down. It's very understandable because lung is smaller. So volume and capacity should turn downward. Any question up to here? Now, if we draw the same thing for obstructive feature, what will happen? I told you that when there is obstructive features, whatever air you bring in every inspiration, you cannot get all the air out. So there is air trapping going on. And if air trapping is going on, lungs will get smaller or larger? Larger. Now, if someone asks you in obstructive lung diseases why lungs become larger, especially in COPD, why they become so large, there are two reasons for that. One reason why lungs are large, simply because they are less compliant. Sorry, they are more compliant. They have less elastic and more compliant. And because they are less elastic, when chest wall is trying to pull the lungs outward, they easily pull out. Is that right? That is one reason why lungs are overexpanded in patients with chronic obstructive airway diseases, because lungs are more compliant and less stiff. But there is a second reason also which is equally important, that in chronic obstructive airway diseases, lungs are also turned into air trapping organ. And when they are trapping the air in, every inspiration they get more, and during every expiration they release less. They trap the air in, of course their size will become smaller, larger? Larger. So it means because they are trapping the air, right, they are larger lungs. Now, such type of person, if he try to bring maximum air out, can he bring his lung volume as small as normal lung? No. So what really happens with these people, they are breathing at higher volume, higher lung volume. These people are breathing at higher lung volume. How come? I'm breathing right now normal lung volume, but now I'm breathing at higher lung volume. Is that right? Of course, obviously I look under distress, and that is the problem here, right? Now, when they are operating at higher lung volumes, so what will happen, that this will be, you understand it? It's higher level. For example, here we put it is 2.5 liter, but for this it was 2 liter. For this it may be operating at 4 liter. It means normal lung has functional residual capacity of 2.5 liter, and during inspiration, expiration, they are changing their size due to tidal volume 2.5 to 3 liter, 2.5, 3 liter. But restrictive lung disease, suppose it is changing 2 to 2.5 liter. During inspiration, expiration, and this lung, because it is overexpanded lung and has trapped lot of air, so it is operating at higher volumes. So naturally, it will be operating during inspiration, expiration, 4 to during expiration it will reach 4.5 liter. Then back during inspiration, during inspiration they will reach to 4.5. Then during expiration come to 4. So this is operating at 4 and plus. Normal is operating 2 and plus tidal volume, and restrictive is operating maybe only 2 and plus tidal volume. Now, if it has high lung volume operating, if you ask the person to do forceful maximum expiration, right, he cannot do much expiration. He cannot do much expiration. Why? Because when this person will try to do maximum expiration, already airways are narrow, and pressure will increase. Many of the collapsible airways will shut down. So can they bring all the air out easily? No. So what happens? They cannot take it down, right? So expiratory reserve volume is less. And if already they are operating at very high volumes, and you ask them to bring forced inspiration, can they do a lot of forced inspiration now? Look, if I'm on high volume operating, now here I operate. Can I take a lot of air in now? No, this is the problem. So, if you want to measure their vital capacity, that is even not much. They cannot bring a lot of air in. So, this is how the spirometric finding in obstructive lung diseases. You can just look and tell. If this is the normal, in restrictive lung diseases, it's operating at lower volumes. At obstructive lung diseases, it is operating at higher volumes. Am I clear? Right? Now, if we write down the general findings, what is here? Total lung volume, total lung capacity. As compared to the normal, it is more. And if you look here, total lung capacity, as compared to the normal lung, it is, yes, less. If I say vital capacity, okay, first you just write here compliance. Here compliance is, yes, more. Here compliance is less. Here stiffness is less. Here stiffness is more, right? Then vital capacity. Here vital capacity will be, vital capacity means that even though apparently lungs are of course very large, but can such lung which has narrow airways, can it bring big changes in its vital capacity? Can it take a lot of air in and out? No. So vital capacity here will be reduced. Is that right? So vital capacity is less. But here also vital capacity is, yes, here also less. Now, why vital capacity is less in restrictive disease? Because the lungs are stiffened. And why here the vital capacity is less? Due to airway obstruction, more resistance to the airways, right? Okay, now we come to the residual volume. Residual volume. In this case, residual volume is more than normal, less than normal? More than normal. Here residual volume will be less than normal, right? Is there any problem in understanding these things? There's no problem. Okay, let me make a test for you. You have to answer me rapidly. I will give you 3 parameters and you have to tell me it is obstructive or restrictive. Total lung capacity is more, residual volume is more, vital capacity is less. Obstructive. Total lung capacity less, residual volume less, and even vital capacity less. Restrictive lung disease. Is that right? Okay. After this, now we come to another concept, that especially to look at the problems here, we have to talk about expiratory flow rate. We say there are more resistance here. If these windpipes have more resistance, if airways have more resistance, do you think airflow will change? Now we will see what kind of change can occur here in the airflow, right? So let's draw some other diagram. First of all, in normal lung, let's draw volume against time. Volume against time. Which volume? Volume the air which is exhaled air volume plotted against the time. Is that right? That is what we are going to see now. Now let's suppose after person has taken maximum inspiration, if a person has taken maximum inspiration and he has achieved total lung capacity, after that he blows out the air as hard, as fast as possible. And we are measuring the air volume. Is that right? And making a graph against the time. Now, let's suppose this goes like this. What is happening? That early time when you're blowing out, lot of air is coming out. Initially, lot of air is coming out. So, with little time, there's a big change in the volume thrown out. Is that right? Now, eventually, maximum volume will be thrown out. The all volume, total volume, which has been thrown out, let's suppose here it is, the volume, initial volume was less and eventually you have brought a lot of volume out. This volume of air which you have thrown out, what is this? Forced vital capacity. What is forced vital capacity? After taking maximum inspiration, you hold your breath for a second and then you blow out as hard, as fast as possible into spirometer, right? Now, when you're blowing out the air, initially lot of air will come out. But as more and more air will come out, less is left behind. So then eventually less air will be coming out. So this is the maximum volume which came out. So what is this? Vital capacity. Because we have brought it forcefully out, it is forced vital capacity. Now let's suppose forced vital capacity here is 5 liter. From this person, normal lung, what is the maximum volume of normal lung? Usually 6 liter. And you can, after total lung capacity is about 6 liter. And when you bring as much you can, you bring about 5 liter out and last 1 liter you cannot get it out because that is the residual volume. Is that right? Now we have brought up 5 liter. Now out of this 5 liter, how much is really brought out during the first second? Right? Now this is the time. Let's suppose this is first second, this is second, and this is third second. Now in this case, if we see, out of this, suppose 5 liter, 4 liter came out during first second. When during the first second of expiration, as hard, as fast as possible, once the lungs have achieved total lung capacity, right, the air which came out during the first second was 4 liter and remaining 1 liter took 1 or 2 more seconds. Is that right? It means the total air which was blown out was 5 liter and out of that 5 liter, 4 liter was blown out during first second. Of course, it means about 80% or 75% of the total, what is this? Forced vital capacity was blown out during first second, right? So what we can say that this volume was forced vital capacity. What was this volume? Yes, who will tell me what is this volume which is brought out during first second? Yes, forced expiratory volume during 1 second, FeV1. Now, if you make a ratio of that, if someone asks what is the fraction of forced vital capacity which is released during first second, that fraction is mainly determined by the airway caliber. The fraction of forced vital capacity which is released during the first second depends mainly on what factor? Airway caliber. If airways are very narrow, then during the first second, less percentage or less fraction of the air will come out, right? In normal person, in a healthy lung, when airways are really okay, is that right? Almost 80% of the forced vital capacity is expelled out during first second. So usually we make a ratio that forced expiratory volume 1 by What is this? Forced vital capacity. What we are trying to determine by this ratio, here it is 4 by 5. Out of 5 liter, 4 liter was expelled out in first second. So what is the percentage now? 0.8, or if you make percentage, it will be 80%. Right? If figures, if FEV1 by FVC is around 80%, that is normal. Am I clear? Now we do the same findings for restrictive lung. Now we do the same studies for the lung with restrictive disease. Of course, in this lung, vital capacity will be less than normal or more than normal here. It will be less than normal. But do you think airways are narrow here or not? Here airways are not narrow. Now, if we draw, yes, we do the same maneuver with the person with restrictive lung disease, that we ask him to first inspire as much he can, achieve his total lung capacity, and then blow out as hard, as fast as possible, right? Then of course all the amount of air which blown out is vital capacity, and then we see what is the fraction which was released during the first second. If we make a graph here, that graph will be somewhat like this. Now, what we really see in this graph is, okay, I will make it rather new diagram so that you can make a comparison. In this case, again, here rather than 5 liter, it has only 2 liter what it could bring out. So vital capacity here has been reduced. Here it was up to 5 liter in normal. Here the maximum forced vital capacity is 2 liter. Is that right? Now we have to see during the first second how much fraction of the 2 liter came out. Is that right? Let's suppose that this is 1, this is first second, right? During first second, right, this much volume was expelled. This is how much? It was 0, 1 liter, here it is 2 liter, it is 1.6 liter. Now what we really see here, even though here the forced vital capacity is less, forced vital capacity is 2 liter. Is that right? Less than normal. But during the first second, forced vital FEV1, forced expiratory volume during first second, that is 1.6 liter. It means even though the total forced forced vital capacity has been reduced, but because there is no airway obstruction, still a significant part of forced vital capacity is thrown out during first second. How much is that? Let's do the ratio. Apparently it looks that here FEV1 was 4 liter, here FEV1 is 1.6 liter. It may confuse a student. The student may think if here in the first second it is bringing 4 liter out, and here in first second it is bringing 1.6 liter out, because in simple relative value it look as if less air is expelled out during the first second. You may think there is some obstructive element, but no. You have to compare what came out during the first second with the total air which came out, right? And if you make a ratio, FEV1 by FVC is equal to 1.6 liter divided by how much? 2 liter. What is the result? 0.8. So what does it mean? That even though restrictive lung disease has reduced the total lung capacity and reduced the FVC, but the fraction of air which comes out during the first second is still 80%. So it means there is no obstructive element in the airways. Am I clear? Any problem up to here? No? Okay. Now we come here and look at this situation. obstructive lung disease. If we draw the same thing, time versus exhaled volume, right? Do you think it can blow out very rapidly? No. Here, even though lungs are bigger, even though here the lungs are larger, total lung capacity is more, but still when this lung will try to bring the maximum air as hard as fast out, because airways are narrow, so can they bring the air as rapidly out as normal lung? No. Air may come eventually out, but very slowly. Is that right? So let's see what happened here. Here, okay, total lung forced vital capacity. Let's suppose it is 4 liter. But during the first second, how much came out? We compare this. Let's suppose this is the first second. This is 1 liter. So what we see in this case, that when time was passing by and forcefully person was blowing out the air, volume which was coming out did not rapidly go, it came out slowly as compared to that. Look at the slope. What does it mean? There is some obstructive element. And how we can authentically talk about, we look at the total vital capacity which came out, that is 4 liter, and during the first second, how much came out? Yes? 1 liter. And if we measure here FEV1, force expiratory volume, during first second divided by, what was this? Force vital capacity is equal to 1 liter divided by 2 is equal to 50%. Is that right? So it means there is significant drop in the fraction of air which was supposed to be expelled during the first second. Fraction of forced vital capacity. Yes, what's your question? 1/4. Okay, then it's a very bad situation. You really want the patient to die. Okay, so she says it's 1/4. Yes, but actually it should be 2 because it's halfway. 2 liter. But even if it was 1/4, it's terrible. So what we said, thank you for correcting. What I was mentioning, that in this person who was obstructive lung disease, his total air blown out was 4 liter, but during the first second he expelled only 2 liter. So out of 4 liter forced vital capacity, the fraction which came out was only 50%. Right? It means that there is airway obstruction, because airway obstruction is present whenever FEV1 by FVC ratio is less than 70%. There's a basic principle that whenever fraction of air expelled during the first second, right, the fraction of the forced vital capacity expelled during the first second is less than 70%, we say there is some obstructive element. Am I clear? Any problem here? No problem here? Okay. Let me mention the same thing in another way. Okay, I will take a little downward. Now we are doing a little different study. Okay, it should be a little narrow. Now, in this case, we have asked the person, he was breathing quietly, then we asked him to bring the maximum air out as much he could, and then inspire as much he can, and then we asked him to again blow out as hard as fast as possible. Previously, in previous graph, expelled air was measured with the time. Is that right? Now we are doing on spirometry. Now, when he was expelling the air, of course, volume was coming down. Now, let's suppose that we measure the time from this area. Here's the time scale. Right? Now, what is the difference from here up to here? Let's suppose this was 1 liter and here it is 6 liter. So how much is this? FVC, 5 liters. The same thing I'm mentioning in another graphic way. What is the forced vital capacity? 5 liter, right? 1 liter is of course residual here. Now, if we are mentioning the time, here is the time for 1 second. It means out of this 5 liter, out of this 5 liter, suppose it was here, this much came during the first, this is first second, so it means this air were expelled in the first second, and after that in second or third second little more air came out. Now what was the total? Yes, no, 1 liter is residual, and when he inspired maximum volume of the lung from 1 liter, it went to 6 liter. How much he was having the air in as vital capacity? 5 liter. And when he, as hard as fast, he blowed out that 5 liter, right? Of course, now volume is becoming less. Listen, previously we were measuring the volume which was expelled. Now we are looking at the graph, the volume which remain inside. It's dropping. Is that right? Now, from 6 liter value, it dropped down. Eventually it will come to the 1 liter thing. 1 liter thing. So how much will come out? 5 liter. Now out of this 5 liter, I have to adjust this second. Second should come up to here. This is the first second. If it is the first second, then from here, from 6 liter up to this, it is, let's suppose, 2 liter, and here it is 1 liter. So it means 4 liter were lost during first second. So what you will, again you can make the thing that FVC is how much? 5 liter. FEV1, how much is this here? 4 liter. And in the same way you can determine the ratio, and that will become 80%. The same information in a different graphic way, right? Now, are you clear about it? Same thing we do with this. What will happen? It should be operating at lower volumes or higher volume? Restrictive lung disease, operating at lower volumes or high volumes? Lower volume. We'll make it here. Now, in this case also, one thing which I did not mention, that is the peak expiratory flow rate. Peak expiratory flow rate means that what is the speed with which you are blowing out. You are getting it? That is the peak expiratory flow rate, which is measured here at the top. Anyway, now in this person, restrictive lung disease, let's suppose it was 0.75 liter. What was this? Residual volume. Is that right? And then when it filled up, in total it became 3 liter. So total lung volume is how much? 3 liter. Is that right? Now how much is the vital capacity here? How much is the vital capacity here? 3 liter minus 7.5. What is the vital capacity here? 2.25 liters. Is that right? Am I clear to everyone, or I am teaching myself? People in the back, they are understanding it what I am doing? Clear? Okay. Now it is restrictive lung disease. He tried to make as much expansion as much he could, but still he could not achieve more than 6 liter. Normally you can achieve total lung capacity up to 6. Here it is only 3 liter, right? And force vital capacity when he blew out, right, maximum right, it was 2.5 liter. Am I clear? Out of this, now we have to see how much it blew out during first second. Let's suppose this is the first second time, right, and out of this much was from here up to here, it released during the first second. Is that right? So we can see the full force vital capacity was 2.25 liters, right? And FeV1 is equal to approximately 2 liter, right? 2 liter came out during the first second. If you make a ratio here, what should be the ratio? FeV1 by FVC. What is the ratio? 2. Yes, who has good math? What is the result? Anyone have calculator or having cerebral cortex? It is less than 80%, more than 80%, or approximately 80%? It's more than 80%. Is it possible? Answer is yes. Sometimes in restrictive diseases it happens that fibrotic tissue pull traction on the airways, they become wider than normal. And when it is trying to blow up the air, because lung has a high recoil, it very strongly push the air out through very wide airways. And even the fraction of force vital capacity which come out during the first second may be 80% or more than 80%. You are understanding? This is a small balloon. It's a small balloon with very strong recoil with very wide opening. This is a little bigger balloon with normal opening. And here it's a very big balloon with little elastic recoil with small opening. Am I clear? Now, so it is more than 80% or 80%. So what I want to say that in restrictive diseases, even though forced vital capacity may be reduced or FeV1 may be reduced as compared to the normal, but the ratio stays near normal, right? Now we come to obstructive feature in the same graphic way. Because when this person will try to blow out, volume will be lost rapidly or slowly? Slowly. So slope changes. Am I clear to everyone? Now, in this case, let's suppose it was here 3 liters residual volume, and here it was 7 liter. So how much was the forced vital capacity? Yes. How many liters? 4 liters. Now we see during the first second how much really came out. Out of 4, half came during the first second and remaining half was still in. You are understanding? So it means out of 4 liter, how much really came out during first second? Yes, 2 liters. So FeV1 is 2 liter divided FVC is equal to 4 liter, 50%. When this ratio is less than 70%, you should suspect obstruction, and it is of course far less than 70%. Am I clear? No problem here. Now, one more concept. There is another concept related with these things. We call it flow volume loops. Keep concentrating on these 3 diagrams. And now we talk about another thing. First normal, and then we'll see what happens in restrictive and obstructive pattern. Now we are doing a maximal flow volume loop or curve. What does it mean? Let me explain. Let's suppose above, this is inspiratory flow, inspiration, and here I will expiration, and here I put inspiration. Here I put lung volume, right? Let's suppose this is 0 volume. Here it is 1 liter. So what is, it may be residual volume, is that right? And then of course 2 liter, 3 liter, 4 liter, 5 liter, 6 liter, okay. Now here we are putting the volume, here we will put the flow. Now let's suppose someone Look at me. I have taken maximum air in. What I have achieved? Total lung capacity. Let's suppose this is my normal lung suppose, and it is at total lung capacity. My residual volume was 1 liter, right? After maximum expiration, forceful expiration, I brought maximum air in, and I reached what level? 6 liter. Now from here, please concentrate. When I've achieved maximum, I start blowing out. When I'm blowing out, here is the expiratory flow rate. Initially, air will come very rapidly. But when air will be coming out, volume will be lost. So airflow will move upward and volume will move in this direction. So when I will blow out after I have achieved total lung capacity, of course when I will blow out as hard as fast as possible, what I will be blowing out? Vital capacity. Now, so what will happen? This curve will move very rapidly upward. I'm blowing out the air and expiratory flow rate is very high initially, but after some time when some part of the air has gone out, the less air remain, and then airflow, expiratory flow will become faster or slower? Yes. If I have achieved total lung capacity, maximum air in, and then I start blowing out as hard as fast possible, initially I will blow out more air and then less air. Initially expiratory flow out or velocity will be high, and gradually as there will be less air left, gradually the air coming out with lesser velocity. Am I clear? So we will see that initially expiratory flow rate is very high, but after some time it start dropping. Oh my God, I cannot reach there. I should put here 1 liter because this was 0 volume. I reach here. So what I have done, that I was at total lung capacity and I blowed out as hard as fast as possible, and when air was coming out, initially at a very high velocity, from 0 velocity to achieve very high velocity, expiratory flow rate, and when there were lesser air left in, then outflow of the air became less until I reached to residual volume. And can I bring further air out? Once I have reached to the residual volume, can I bring more air out? No. So expiratory flow will become 0. Is that right? After I have done this is the maximal expiration. Now I do the inspiration. I again listen. Let me repeat. This curve is showing that now I start from here. I'm taking the air in back. When I take the air in back, I again start filling the lung from which position? From 1 liter, I will bring it where? The 6. Now this inspiratory curve, right? Inspiratory curve will move like this. What does it mean? When I start inspiration, in the very beginning of inspiration, there is no air coming for inspiration. The inspiration becomes faster, faster, faster. When lungs are significantly filled, then I'm pulling the air in relatively slowly. And at full inspiration, at total lung capacity, I cannot pull in more air. Is this loop clear? Right? So, with maximum air, first I will blow out and this will go, then I will pull the air in and this again. Okay, I start from here. Am I clear? No problem with this loop? Clear to everyone. Now let's suppose I have an obstruction in my trachea or extra pulmonary airways. I have some obstruction. If I have that obstruction, when I will try to pull the air in, can I pull as hard as fast? No. So I'm changing it. If there is some obstruction, I start with 1 liter. If there is obstruction in tracheal or extra pulmonary airway, I will pull the air in from 1 liter to the 6 liter, but relatively slowly. Is that right? Because there is obstruction on the way. This is obstruction in the larger airway. So this loop will move like this. And when I have an obstruction here, I try to blow out as hard as fast as possible. Can I achieve this flow rate? This is peak expiratory flow rate. Can I achieve that if there's obstruction here? No. So again it will go like, am I clear? So it means that maximum inspiratory velocities could not be achieved and maximum expiratory velocities could not be achieved. This is a hallmark of this change in the loop, is a hallmark of obstruction in extrapulmonary airways. Is that right? Now we see what happens in restrictive lung disease to this loop. Now let us suppose, now I'm a person who is having fibrotic lung. If I'm having a lung which is fibrotic and this is a lung which is very stiff with very high recoil, in this case, let me draw. Now in this case, if this is zero volume, I will draw with green color. With green color, I am going to draw the same flow volume loop in restrictive lung. First of all, do you think it will start at 1 liter residual volume or there's less residual volume in case of restrictive lung disease? Less. Is that right? Residual volume is less, smaller lung. So maybe start with the half from here. When I will start inspiration, can I achieve up to this level? No, I can achieve this velocity, but I cannot achieve from here to here volume. Again, listen carefully. This is a fibrotic lung, but airways are wide open. Is that right or not? When I will start doing inspiration, right, because airways are wide open, very rapidly air will come in. But because I cannot expand it much, I cannot achieve a very big total lung capacity. Is that right? In normal person, in a normal lung, you started with 1 liter and we pulled air in and reach up to 6 liter. Here you started with a half liter and maybe you reach at 2.5 liter. Right? In restrictive lung disease, lungs are smaller. So residual volume is very less as compared to the normal. And when you start inspiration, inspiratory flow increases. And eventually it decreases when total lung capacity is achieved. As compared to the normal person, normal lung, total lung capacity is 6 liter. Here maybe total lung capacity is 2.5 liter. Am I clear? Anyone who is terribly confused, raise your hand. Just to remind, everyone has 2 hands. Everyone is clear about this thing. You are understanding this loop. Great. I could not understand it for so many years. Yeah.
Just a quick question. Is the velocity in restrictive the same as the normal lung velocity?
Velocity with which the air is going in?
Yes.
Right. That may be little less.
Oh, it is a
Little less. The reason being that because it is stiff lung, it cannot be very rapidly expanded.
right on your graph.
Velocity depends on 2 things. Just 1 minute. The velocity with which air will go in, it depends on 2 things. Number 1, caliber of airway. Number 2, how rapidly lung is expanding. Airway caliber here is okay, but because lung is rigid or stiff, it cannot be expanded as rapidly as normal. So it is not going as down. Is that right? Secondly, this lung will expand from half liter residual volume to maybe 2.5 liter of what? Total lung capacity. So vital capacity is only 2 liter. Now after this, when it will start blowing out air, this small lung, when this person will try to blow out air, do you think there will be problem in blowing out the air or no problem? There should be no problem, rather there may be easier. You know why? Number 1, because airways are well open, there is no problem with the airway. So expiration should be problem free. Secondly, because lungs are stiffened, during expiration recoil is more. Because lung recoil is more, it will more rapidly throw out the air. So what really happens, that curve, the only difference now, normal is the black curve and green is the restrictive disease. Note the differences. In restrictive diseases, what is this? Residual volume is less than normal, right? In restrictive diseases, from residual volume up to total lung capacity is what? Vital capacity. As compared to the normal lung vital capacity, restrictive diseases vital capacity is less. But shape is similar. It means still about 80% of the air is blown out during the first second, right? Shape is same. Another thing, but peak expiratory flow rate is less than normal, because normal lung with very high velocity throws a lot of air, because it was having less air in total amount, so it could not achieve the expiratory velocity of the normal lung. Am I clear? Or teaching myself? Okay, now we are going to talk about same flow, maximal flow volume loop for what is this? Obstructive lung disease. Yes. This thing? This was for the tracheal obstruction. Tracheal obstruction. This is normal loop. This is restrictive lung disease, right? Now I'm going to draw what? Obstructive lung disease, 6, 7, 8. Now, in obstructive lung disease, first of all determine, in obstructive lung disease, what is the, residual volume. What do you think? If normally residual volume is 1 liter, in restrictive disease it is half liter. In obstructive lung diseases, air has been trapped. So in obstructive lung disease, what is this thing? Residual volume will be less than 1 liter, less than normal or more than normal? Maybe it is 4 liter. So from here, inspiration start. Now, from 4 liter of residual volume, when inspiration start, is that right? Again, during inspiration, problem is less, because airways open. Real problem will occur during expiration. So what will happen? From 4 liter it has to achieve very high total lung capacity, maybe. How much is this? 8 or 7.5. Or let's take it to 8. Right? Now the real problem comes that in obstructive lung disease, during inspiration, maximal inspiration of, right, when it started from residual volume, it could take the air in a normal fashion, because during inspiration still airways were opened as lung was expanding, and it achieved very high total lung capacity. Once it has achieved this level, now it has to blow out as hard, as fast as possible. Now problem will occur. When it will blow out, right, because these are somewhat obstructed even from the beginning, do you think air will come with very high velocity or relatively low velocity? Relatively low. So rather than like this, it will be little like this. Number one. Do you think peak expiratory flow rate which is achieved here can be equal to this one? No. And now, listen, when first part of the air blew out, but when lung becomes smaller, air will become really very small. You are understanding? Initially, air came out with moderate velocity, but some amount of the air came out in obstructive lung disease. As some amount of the air came out, lung got smaller, they become really very, very small. Now it becomes very difficult for it to expel the air. Suddenly, velocity of flow out suddenly drop rapidly. Why? What has happened now? Airways are becoming very, very, narrow, obstructive element. So it cannot expel well. Rapidly, velocity of air which was coming out dropped. And then very prolonged expiration with low velocity. Here was expiration velocity. Is that right? Now, so what is this? This is a sofa on which you can sit because you have some obstruction, in your airway, right? So this is the different pattern which you can see in maximal flow volume loop, right? On this axis we are looking at the volume, on this axis we are looking at the flow. Am I clear to everyone? Okay, let me take a test of you rapidly, what we have learned today. I'm going to draw A, B, C. Here is pressure and here is volume. Yes. Which is the restrictive pattern here? B. And which is obstructive pattern? C. Good. Now I will draw three things. Yes, A, B, C. Which is restrictive and obstructive? This is pattern number 1. Pattern number 2. Pattern number 3. Pattern number 4. What is pattern number 4? What is pattern number 2? What is pattern number 1? And pattern number 3? Class dismiss.